Thank you, Deb. Welcome all, and thanks again for joining us. This is our monthly virtual fireside chat, now become a little bit of a tradition here. So thanks for joining online with us. As many of you know, my name is Adrian Gardner. I'm the Executive Director for the AMPATH Consortium and Director for the Center for Global Health. I'm joining here from Indianapolis, but for the last 7 or 8 years, I've been in Eldoret, Kenya, where we led our weekly fireside chats at IU House, which really provided a space for learners and faculty, visiting faculty, to learn and reflect with our trainees and visitors. So this tradition began back in the 90s, and we used to have we still do have a fireplace in House 1 where we sometimes used to congregate around, and then for a few years we were outside around a fireplace where John Humphrey's kettle corn will go down in history for livening up our fireside chat. But obviously in this day and age, we've taken this virtual, and it's been a great way to keep us all connected. So today we are very privileged to be hearing from some of our leaders in our mental health efforts. As you all know, mental health is really a huge issue in Kenya. There's tremendous need, and it really cuts across all the programming that we do, regardless of which disease state we're talking about. And a lot of stigma and misunderstanding, and our panelists today are really leading the way in terms of our response. So Dr. Edith Koba, who's a psychiatrist at Moi Teaching and Referral Hospital, Dr. Florence Jaguga, another psychiatrist at Moi Teaching and Referral Hospital, and Dr. Matthew Tirasini, who's our Associate Field Director for Population Health at AMPATH, and also a former team leader. And so again, as Deb said, as a reminder, if everyone can keep themselves muted, but feel free to chime in anytime during the chat. Please engage with us by chat. We can stop and answer questions, or we can at least collect them and address them afterwards. And again, thank you all for joining us, and I'll turn that over to our panel.
All right, thanks, Adrian. I think maybe if each of us just introduces ourselves quickly, just a little more of our background. And Edith, do you want to go first?
Thank you, Matt, and thank you everyone who is able to join us this afternoon. For those in the US, for the rest of us, it's actually night. It's actually 8 p.m. We just had dinner. And I'm excited to be here this evening to share a few things about mental health. I'm a psychiatrist at Moi Teaching and Referral Hospital. I graduated in the year 2013 with a Master of Medicine in Psychiatry, after which I worked for about 10 months in a place called Kakamega. And because my husband has always been in Eldoret, I quit to join him. And since 2014, I've been heading mental health at Moi Teaching and Referral Hospital. It's been an exciting journey, but the most exciting bit is the chance that I've had to expanding mental health, especially in primary care and community health settings. And I'm happy to have Joe around, and Adrian, and other people who've really been behind this. And I want to say that, and so AMPATH and Eldoret has given me a chance to do those community health programs, and it's been very, very exciting, and we'll be sharing more about that. Other than that, I have a family, and it's exciting to be around with them in Eldoret. It's one of the reasons why I quit in being in Kakamega, and I hope that going forward, we're going to share a few things about what we are doing in Eldoret. Thank you. Back to you, Matt.
All right, and Florence, do you want to give an introduction?
Yeah, sure. Thank you, Matt. Florence Jaguga, a psychiatrist at Moi Teaching and Referral Hospital. I head the alcohol and drug abuse services at MTRH. I also work with Edith and Matt on some community mental health programs. I'm particularly passionate about substance abuse, having seen from the time I joined psychiatry how bad alcohol abuse and cannabis abuse was affecting people out there, and how there was limited access to services, how there was so much stigma surrounding alcohol and drug abuse. So I'm very passionate about it, about making sure that people are able to to access the care they need. My goal really is now to integrate alcohol and drug abuse interventions into primary health care. What's happening right now in Kenya is that a lot of the treatment is in highly specialized facilities, but that's only for a fraction of people with severe alcohol abuse. But what happens to the majority of people who just have harmful patterns but are not really severely ill? We do need to integrate substance abuse treatment into primary care, and that's my goal and ultimate vision. I'm a mother. I have 3 children, a husband as well. I'm happy to be here to talk about mental health and interact with everyone who's here. Thank you, Matt. Back to you.
My name is Dr. Matthew Terracini. I'm obviously the odd one out. I'm the only non-psychiatrist on our leadership team. And I'm double board in internal medicine and pediatrics, and have been going back and forth to Kenya since 2009 as a medical student at IU, and spent almost 2 years in Kenya between all of my medical training, and then I've been back there full time outside of global pandemics for the last what would be 3.5 years right now, but we've been back for a little while. And I co-lead the health system strengthening arm of our population health initiative. And part of that, in an area where obviously more capacity is needed, is mental health. And I think it'll become clear through this talk that I have a pretty clear role on this team. I cut the grass in front of Edith and Florence so they can run. And so let's kind of get into it. We'll be kind of giving a brief overview of mental health disorders in Western Kenya, talking about the history of some of the empath healthcare programs over the years, and then talking in more detail about what we're doing now, and then going into some discussion and questions for whatever people are interested in talking about, and hopefully making that as participatory as possible. So Edith, you want to tell us a little bit about mental health in Western Kenya?
Yes, thank you very much, and thank you for sharing that photograph. It's some of the teams that we've been meeting in the communities, and it's always a very, very exciting journey to work with these people, especially because many of them would not have probably access to mental health care, maybe had we not reached them. And talking about mental health in Western Kenya, I want to start by saying that it's not really specific in Western Kenya, but even Kenya in general. The practice of mental health has always taken a backseat for many reasons that many of us understand, that there are many other things that seem to be a priority for the governments that we serve, whether that is HIV, that is malaria, diarrheal diseases, pneumonia. So most of the time, mental health has not been seen as a priority, especially when you think about it in a setting where the understanding of mental health, or of health generally, is that you are considered unwell if you have symptoms that can be measured and that are clearly understood. So mental health in Western Kenya and in Kenya generally has always been not well understood. And the other thing that has characterized the practice of mental health in Kenya, and specifically Western Kenya, is the limited human resource for mental health. And I remember when I graduated in 2013, I was one psychiatrist who was covering like 2 provinces with more than 10 million Kenyans. And the next place where people would seek help would be in Eldoret, where at least there was a higher concentration. At least there were 4 psychiatrists because of Moi University. And that has always been the case. If you think about it, since Kenya started graduating psychiatrists, we just slightly hit the 200 mark, and there are many who are not practicing. So there's significant limitation in human resource for health. The other important thing that we'll probably be mentioning later is the fact that even the budgetary allocations for health has always been, as World Health Organization indicates, less than 1%. So that would be the characteristic of what mental health looks like in Western Kenya. And so when I came to AMPATH in 2014, one of the things that I was lucky to have an opportunity to do is to interact with Joe and Adrian. And there came a Fogarty, and we did a baseline survey within Western Kenya to just find out is Western Kenya different? And what I'd like to report is that it's not different. We established that the disorders that affect the rest of the country and the rest of the world are still the commonest disorders. We're talking about anxiety disorders, which affects about 16% of the population in Western Kenya. We are talking about major depression, which affects about 12%. Then alcohol and substance use, which is the passion that Jaguga has, is 12%. Then we had one of the interesting things that we found out is that quite a number of people, actually almost 8%, had experienced a psychotic episode, even when they didn't fulfill the criteria for major psychotic disorder. And the other interesting, well, yeah, to call it interesting, is that about 17% of the people that we interacted with had actually had a suicidal attempt in their lifetime, which was very surprising. And overall, 45% of the people in Western Kenya have had a lifetime diagnosis of at least one mental disorder. But the unfortunate bit is that out of the people that we interacted with, only about 1.7% had actually been diagnosed with mental illness, in the sense that they had been seen by someone, told they have mental illness, and on follow-up, agreeing with what World Health Organization has described as a huge treatment gap. And unfortunately, one of the other things that we established along the way is that many people would not be open to seeing a mental health practitioner because of the stigma. And when we talk to them, most of them would be talking about things like career guidance. That's what the closest they have come, they have thought would be the source of help. So mental health is common in Western Kenya, and many people go untreated. The disorders are the same. And other than the community, because this was purely a community study, the other thing we would like to mention is that we see the same trends in Moi Teaching and Referral Hospital where we practice, because while we know that there's a lot of anxiety and depression, unfortunately, if you came to the clinic where we see patients, very many patients, every Wednesday at least we see about 100. You hardly see depression, you hardly see anxiety, you hardly see anything else. And this speaks to our understanding of mental illness. You see bipolar mood disorder, because mainly this might be the most irritable patients who people would recognize as unwell, and you also see schizophrenia. To mean that there are many people out there who are continuing to suffer without the knowledge that just feeling sad, which is depression, would actually be an illness that can be treated. And probably this is what has culminated to us seeing more and more suicides in the country. Although we haven't done a study, it has become very clear that we are reporting more suicides in the country. We are reporting more suicides in Western Kenya. And it could be because of this depression and anxiety and substance use, which has never been recognized as an illness. And we are hoping that going forward, as we continue in educating people along the way, they will understand. And unfortunately, most of the time, people think that you should only see a psychiatrist if you're psychotic, which is in Kenya, you'd say you're mad. But if you're just a bit anxious, then we don't think that it's illness. And its prescribing has been threefold, and we are going to give you a bit of more detail. That first, we want to educate the public about illness, what mental illness is, which brings them to hopefully want to seek help, but also fight stigma. The other thing is that we do screening, and screening then increases the chances of these people being treated, and then we try to follow them up in different ways. So that's what I'd say about mental health work and the mental disorders that we've been seeing in Western Kenya. Back to you, Matt.
Thanks, Edith. And so the next thing we want to talk about a little bit is kind of the history of mental health care programs within AMPATH and what that's looked like over time. The three of us, Edith Florence and I, as well as Julius Barassa, are a program manager for our mental health work. Recently had a book chapter accepted on this that it's not in kind of final release form, but hopefully we can share that out at some point. And the goal of that book chapter was really framed as describing a stepwise approach to developing mental health interventions in the community over time. We know that mental health is a need, mental health services are a need basically everywhere in the world. And similarly are underfunded almost everywhere in the world. And so we need to start somewhere. And so I think AMPATH's history is largely kind of starting somewhere and then moving forward and growing something from that. Really, the care services in AMPATH for mental health started in the HIV care program with providing mental health care to HIV patients. Professors Mengith, Atoli, Gakinya all had a role in that. We had a psychiatric nurse named Lillian, who is a huge lead in kind of developing and pushing forward that mental health care for patients. And so I think that's kind of an important place where things started. But then also really Moy Teaching and Referral Hospital as the host institution growing mental health services over time. It certainly when AMPATH started in 1990, there wasn't a psychiatry department. There wasn't for 20 years probably. Edith, do you know what year the psychiatry department MTRH started?
No, I'm not very sure. I found it right.
And so so part of it was MTRH growing mental health services, and that includes an inpatient mental health ward, consult services within the hospital, mental health clinics. But we also know mental health can't be only at tertiary referral hospitals. MTRH is one of 2 public tertiary referral hospitals for the country and covers 22 counties and half the population of Kenya. That's not enough for mental health. And I think AMPATH's really first initiative to start developing and improving mental health services outside of the referral hospital and for HIV patients was what Edith was just talking about. When she came and joined as faculty at Moy Teaching and Referral Hospital, she had a passion for community-based mental health services, that it wasn't good enough just to treat the sickest of the sick once they needed to be in the hospital. We needed to get out in the community and get care to other people. So she initially had the Fogarty grant supported through Duke, which Joe and Adrian helped her get to kind of look at some of the baseline numbers she just talked about of prevalence of mental health disease in the community and how many of those people actually were getting care. And I think one of the striking things was, although 45% of the people in that baseline assessment could describe at some point in their life had a mental health disorder, less than 2% had ever sought care or been able to obtain care, maybe more sought care. And so that was a really significant gap. And so from that initial baseline study, Edith then took her passion and kind of drove and got funding from IU, including some donor funds, to start really doing the first care programs in the community that AMPATH was supporting. And that started with a few different approaches. One being community entry, engagement, education, and addressing stigma, and then addressing capacity building with training CHVs, training clinical officers and nurses. And that all started in Nandi County. And then as the AMPATH population healthcare program kind of grew and developed, it spread onto Turbo Sub-County and Wasingishu County, and kind of scaled up really to be part of our population health initiative. Instead of focusing as just developing mental health, we need to grow an entire care system. Mental health depends, like treatment for many diseases, mental health care depends on having a good supply chain of medications and good leadership in facilities and good linkage systems in the community. And a lot of those care programs we had in Wasingishu and Nandi County then informed kind of growing out the services that we've continued to expand now. And we'll go a little bit more into detail with our current programs about clinic-based care, community-based care, as well as the transitional home that we're starting. And since we'll address all of those in more detail with current programs, I won't chat about them now. I will show kind of a quick map of the impact catchment area. So all the counties in blue are part of the HIV catchment area, and these counties in green, as well as Nandi County, which isn't shown here, are all counties where we are doing some mental health work currently. All right. So Florence, do you want to chat a bit about the transitional home?
Yeah, thanks, Matt. So in 2019, the AMPATH Mental Health Program received funding from Astellas Global Health Foundation to further support the mental health work that was already ongoing in Western Kenya. But in addition to that, the funds were for the construction of a transitional home that you can see on the picture there. This is the current state of the construction, and it's really exciting. So the purpose of the transitional home is actually to provide a psychosocial rehabilitation. So what we discovered was that there was following acute psychiatric care, need for patients to be equipped with skills to facilitate reintegration into the community, skills that were going to allow them to earn an income, to be able to be functional in the society, skills that would really improve their quality of life. And the transitional home is going to be this place where we are going to admit these patients post-acute care and equip them with skills like vocational training, which will be things like beadwork, like soap making, just the kind of skills that would allow them to earn an income. Beyond that, they're going to be taken through things like life skills training, budgeting, financial literacy, social skills training, just making sure that other than managing symptoms, we are also focusing on psychosocial rehabilitation in a way that ensures reintegration back into the community, in a way that ensures wholesome recovery that just does not focus on symptoms. So this is what the transitional home really is about. And I'd like to say that this is the first of its kind in Kenya. And I'm also happy to say that we are constructing it in line with the requirements of the Convention on the Rights of Persons with Disability. So just making sure that we are, while constructing it, we are upholding the rights of persons with disability. Thank you, Matt. I'll hand it over to Edith.
Thank you, Florence. Of course, when you talk about this transition home, it's always very, very exciting to know that we can, how you can dream and it actually comes true, and we really appreciate Astellas for this opportunity. Now, the next thing I want to talk about is the clinic-based services that we're offering, still part of Astellas program, but also had been funded by some funds from IU. I call them philanthropic funds because that's what Joe called them. He only knows where it came from. And I want to give a little background about where this passion came from. I remember when I went to Kakamega, some 100 kilometers from Eldoret, I was really passionate about going to communities. And I remember we had an old Peugeot 504, which would be given by the hospital to go to the communities. But one of the things that struck me really was that there are people who will never access mental health care for many reasons, including poverty, including lack of awareness, until we came with our vehicle to see them. And the relatives would be very, very happy that we actually showed up. And they would be so far from care that even when we drove through on rough road, you almost get their distress in trying to access care. But the one thing that struck me was that this nurse who received us, who deliver children, would actually do the work of an obstetrician. They also had a HIV clinic. They also were managing even people with diabetes. And the one thing I was sure is if they could do all those things, they surely could do something for mental health. And I think that's a basis of the clinic-based services, where we are saying it's great that people can come to Moi Teaching and Referral Hospital, but most of them would have to travel long distances. And sometimes if they have not killed anyone or burnt a house, for sure some relatives had rather that they stay because it's too much work. However, this clinic that I saw in Kakamega, first of all, if you come to Moi Teaching and Referral Hospital, it costs $3 for you to be seen. But if they went to the clinic where they were going to be seen, it probably some cents. It's very, very cheap. And the drugs, they are, as much as they are great drugs, probably in MTRH, they are cheap drugs that really can manage these patients. And one of the things I was told in those clinics was the drugs would just expire because there was no one to be prescribed for, not because there was no one, but because the staff didn't understand or they were not willing, they just sent them over long distances. And what hit me is that many people had rather not travel, especially when poverty comes in, because the cost of traveling will be too much worth a meal for the family. So why bother this one person who has weird behavior and go without food? And that's the whole concept of bringing the service closer to the people. So how do we do it? So we, first of all, do the community education so that the community is aware of what mental illness is. The second thing is we build capacity for the clinical officers and the nurses. Clinical officers, for those who may not be familiar with, that are the physician assistant. They don't go through the whole medical school, but they do a 3-year course and give them the basics of practice of medicine. And we educate them about how does depression look like. They may not understand the whole pathophysiology in detail, but at least they understand how depression looks like and they can screen for it and they can initiate care. Then we work with the medication that they could have at that clinic and teach them how to utilize it to initiate care. And at the same time, and I know that this is a major concern in many places about task sharing, task shifting, and quality of care, ensuring that they know who to refer. So I know by the time I came to Eldoret, and I never would like to take all the glory, is that my predecessors had 3 clinics in Osorio, Talbo, and Band Forest. But what we have been doing is to increase that, expand that, so that as the patient walks in to a health center near them, and they had depression, instead of being treated for brucella or typhoid that never respond, that's what many people would call it, that this is your typhoid never goes away because you have so many symptoms, then they are able to say, wait a minute, this person has depression. And so far we have trained quite a number of healthcare workers. At least we have trained more than 100 nurses and clinical officers using the MHGAP, Mental Health Gap Intervention Guide by World Health Organization. And we continue to mentor them and supervise them. And one of the things that we have also learned is to identify a champion. I know, like even just today, I'm on leave, as it were, but when a gentleman called Douglas, who's one of the clinical officers, somewhere in one of those clinic calls, I know I have to respond because he definitely will have a patient. So we continuously supervise them, we continuously encourage them to call to ensure that they're able to see, and we also love to encourage them to refer. I remember today when the clinic officer from one of the clinic called me, he said, I want you to see this one. I have tried my best. But the beauty is this patient has not been suffering. So that's what we call the clinic-based care, working with the community to educate them, empowering the clinicians and the nurses to recognize mental illness, using the resources they have and ensuring that they are able to refer appropriately. And with Astellas, we've been able to expand this further. And then what has happened is that now we have a clinic officer who is even mentoring more closely. When Florence and I are overwhelmed, we have a psychiatric clinic officer who has been reaching out to more clinics. So that's what we are doing, and I can say it's been exciting, and we believe we are reaching more people than we would otherwise have reached if we were just sitting in Moi Teaching and Referral Hospital and waiting for them to travel. Thank you. I think back to Florence to tell us about the alcohol support groups in the community.
Yeah, thank you so much, Edith. So there's quite a bit of community work that has been going on. And I think, Edith, you've alluded to some of it. One is that there's been public education. This just involves giving talks about mental health to different forums. It could be at what we call chiefs barazas. It could be at meetings for local leaders. It could be in churches, but using such fora within the community to talk about mental health. And the aim is really to improve mental health literacy in the community. There's very little understanding about mental health, what causes it. There's a lot of myths surrounding the etiology of it, and also public education aims to reduce stigma. And then the other thing that we do in the community is to screen for common mental health conditions. Specifically, we screen for depression, psychosis, and substance use. And a lot of times we use this fora to screen for mental health conditions. And then those who screen positive now at those points are then referred to the healthcare facilities that Dr. Edith is talking about. And then there's already capacity building at those primary healthcare facilities. So then they are ready to receive these people who screen positive. And the people who are helping out with the screening is community health workers who have been trained. And I'm a believer of using lay providers to deliver mental health services, just so that you're increasing access to mental health care. And to date, we've actually trained more than 30 community health workers, and they're the ones doing that kind of screening in the community. More than 8,000 people have been screened, more than 500 people have been linked to care. So there's been quite a bit of impact with the work that's going on in the community in Western Kenya. And again, I'd like to say that offering mental health services in a setting that is not restrictive, that allows for people to still be within their communities, again, is in line with the Convention on the Rights of Persons with Disabilities. So we are taking care of them, but we are also upholding their rights. So other than that, we also have alcohol support groups in the community. As I had said earlier when I was introducing myself, there's a huge treatment gap for substance use. There's like 3 rehabilitation facilities for the entire country, serving almost a population of 50 million. So you can imagine how difficult it is for people to be able to access substance use disorder treatment. So what we decided to do was set up support groups within the community and train peers, persons in recovery, and also train community health workers to lead those groups. And we've seen quite a bit of success. So a story that comes to mind is of this lady who had been using alcohol for quite some time. She had not been able to save up. She was living in like extreme poverty, I would say. But then through the support groups, she was able to stop alcohol use. She was able to construct a stone house for herself. I wish we had pictures of that here now. But that was really encouraging to see that measures such as support groups within the community that are led by lay providers who've been trained can have such a powerful impact. Yeah, thanks, and I'll hand it over to Matt.
Thanks, Florence. And our current work is primarily supported by the Astellas Global Health Foundation, and which is awarded us a 3-year grant to build this transitional home, to scale up our community-based services and our clinic-based services. And the goal of all these interventions is that they should sit within long-term sustainable infrastructure. And so the transitional home is on Moy Teaching Referral Hospital property, and with the idea that it will be a long-term part of the hospital mental health program's functions. The community-based care, we're focusing on working with community health workers who are and community health volunteers who are part of the Ministry of Health overall infrastructure that these counties already have. Similarly, with the clinics, our plan is not to develop new clinics that we're supporting, and then if grant money disappears, then they're no longer able to be continued. We're putting a lot of energy into making sure that we are supporting the development of these clinics within the county Ministry of Health infrastructure. And so to describe what that means, it's working on things like supply chain within the county systems to make sure that drugs are available. It's training up providers. It's then developing a system where those providers at a lower level facility who don't have as much training have someone who they can call to get more information to how to treat a more complex patient, or even to troubleshoot ideas. And so we've expanded out to multiple counties and are really taking finding new places to implement this is largely based on interest and commitment from those facilities. Then we support them in growing it, rather than us just placing one of our own clinical officers there to provide the care. And as Edith mentioned, the number of mental health personnel in Kenya is significantly less than where it needs to be. The current ratio of psychiatrists to the population is about 1 to 500,000 people. I think for any medical specialty, that would be too few, but especially mental health, where you really need time with the patient. You can't just write a script for high blood pressure and kind of move on. This is kind of significantly less than what's needed. And similarly, psychiatrists, medical social workers, psychiatric nurses are all too few. So we are also partnering with a number of training programs, including one in Nairobi that does psychiatric nurse and psychiatric CO trainings, and trying to partner with the counties to help get them kind of specialty trained up providers, but also knowing that mental health care is always largely going to fit within primary health care. And so training up who's doing primary health care in these facilities so that they're able to address mental health needs as they come up. There have been a number of areas where a number of kind of challenges that we've met, but also lessons learned as we're trying to figure this all out. But I think it's probably best to let's go into some questions, and we have some discussion points we can use if needed. But let's kind of see what questions or discussion points other people have, and then we can frame it around that. And if there aren't many questions, we can always talk a little bit more about future directions or other areas.
So guys, there's a number of really good questions in the chat already. I don't know, can you guys all see the chat, or Edith and Florence?
Yeah, I'm bringing it
Yes,
up.
we can see the chat.
Okay. So Matt, I don't know if you want to read, or I can read. The first one is from Richard, just drawing parallels to palliative care and his experiences in Uganda and Kenya, where mental health is really on the sort of periphery of the global funding agencies. And I think it's absolutely true. He's asking, how do we relocate or reallocate mental health so it's more center stage from a funding perspective? So I think, Matt, you've alluded to some of this already in terms of making it a key component of primary health care and our sort of population health strategy. But I don't know if you guys want to share anything else about.
Yeah, and one of the other things I'd like to say is that there's been limited research. I think sometimes you need evidence for the problem so that people can recognize that it requires to be like a seat of its own, as I'd call it, yeah? Instead of being somewhere at the back seat all the time. So I think we need to encourage ourselves to make sure we document what we are doing and do research, even if it's not greatly funded. We can do research, it's even small research at like at a clinic level, so that out there, the burden and the impact it has on people can be recognized. And that's what we are, even at the community level, we are already trying to do that. Like we have a study that we are doing to evaluate these core support groups. Are they making sense? And is it something we'd recommend? So that's the other thing that will encourage a lot of research documenting the magnitude of the problem.
And I think, like palliative care is seeing a little more interest globally. I think mental health, luckily, we're seeing a little more interest globally over time. The Wellcome Trust out of the UK, which is a kind of large research funder, just a month or two ago, reset its global priorities and just instead of, and to 3 specific areas, with mental health being one of them. And so we are seeing some movement towards it, but I think it's, you know, I mean, I can't think of any countries where mental health takes as much center stage as it probably needs to. And so it's a great question, but I don't know in terms of funding perspective outside of, I think as Edith said, like kind of the more we can raise awareness and present potential solutions for addressing mental health in low and middle income settings, I think that's going to be really fundamental to creating opportunities for funding.
What does the people say about a country? You can judge a country by how they treat their mental health, those who suffer from mental health, and their prisoners.
Yeah.
I think the other thing to mention just is, you know, Richard, we've had a long-term support from Lilly, who has donated fluoxetine and Zyprexa, antipsychotic, which have been key components of our sort of medical pharmaceutical formulary in terms of addressing some of these needs. So, Mary was pointing out that with COVID, we've seen a huge rise in rates of anxiety and depression among particularly young people in the US. And I know you guys have been involved with some of the adolescent efforts there in Kenya. I know you've also written an article I just found on COVID and mental illness, which I shared in the chat there. So if anyone wants to look at that. But Edith or Florence, do you want to comment on that?
I think I'll go ahead. There's not been research that has been done looking at the mental health outcomes of youth during this pandemic. I know Edith and colleagues have done a study looking at the mental health outcomes for adults, and there's one that's ongoing looking at adults who are in quarantine. Nothing much for youth, but as far as I can see from studies that have been done previously, the rates of anxiety and depression among young people, 15 to 24 years, are really comparable to what we see in the adult population. There's one study that a colleague of ours did among adolescents in Nairobi, and the study found pretty high rates of depression at 13%, anxiety at 6%, substance abuse at 30%. So really what we see in the adult population as well. And what I consistently see again is that adolescents frequently don't have access to mental health interventions. I think really because they don't have money, there's limited services again, and we don't have services that cater to the needs of young people and adolescents. So I'd be concerned about the mental health of youth at this time.
Edith, anything else to add? Or actually, we got lots of questions, so maybe we just keep going.
I will say Florence did just and Edith did just submit and didn't get funded for, but a large grant specifically looking at mental health and adolescence. And so I think it's an area we're trying to expand on and really looking to grow that area.
Matt or Edith, maybe could you talk about the sort of plans from for transitioning people from the ultimately from the rehab home? I know that the rehab home represents a transition from inpatient care back to community, but what are the plans for sort of that transition?
Florence, do you want to answer that since you're working on the therapy manual right now?
Yeah, sure. I think the one thing I forgot to clarify was that so it's not going to be a long-term care kind of home. It's going to be a place where we are going to have residents stay for an average of 3 months. And we feel that a 3-month period is enough for them to gain the skills they need to facilitate independent living. So it's not, we don't see it as institutionalization, because I think institutionalization kind of means long-term stay, but this is just a very brief period with very focused goals for making sure that they're able to live independently. And then also the group home is being constructed in a way that reflects the manner in which people live in the community. So it's not going to be like wards. There's not going to be a daily prescribing of medication. We're going to try as much as to make it as homely as possible. There's going to be involvement in daily activities like cleaning and cooking. So trying as much as possible to mimic what's happening in the community.
And I think in terms of aiding that transition back to the community, we have a social worker who is currently going to be kind of the lead of that home as it starts up, who's been helping us write our operations manuals and therapy manuals. And so we'll have a case management system included in it with making sure people's communities and family are involved. It's actually one of the kind of criteria to move to the transitional home is you need to have people in the community who are working with you, and those people are going to be part of the process throughout the stay at the transitional home. And then we're partnering with a number of other organizations in terms of the vocational skills training that hopefully will allow for some of the employment linkage opportunities and can facilitate that. Because this is a first of its kind project in Kenya, I think we have a lot of lessons to learn. But I think we're trying to plan out as much of that as possible. But some of our first residents are really going to help us figure some of it out over time.
So Matthew from AIC and one of the South Rift was asking about whether he can access some of the training materials. I wonder if maybe we could just link you guys offline and see if you can touch base. Matt, there's a couple of questions about community health workers or community health volunteers, just broadly about the distinction between them and whether they're being sort of cross-trained, or these individuals sort of dedicated specifically to mental health, or how that's working.
So these are cross-trained individuals. Because of the funding allowed for mental health within the Ministry of Health and county health systems, I think anything we set up that has a large cadre of mental health specific staff in it at lower level facilities in the community is going to be financially unsustainable. So we're really looking at how do we add kind of capacity, both in terms of quantity and quality of mental health care into the primary health care infrastructure that already exists in all of these places. So in Western Kenya, the counties that we're working in, so Uasin Gishu County, where Eldoret and Moi Teaching and Referral Hospital is, has about 1.1 million people in the county and has roughly around 160 county health facilities in it that are pretty widely distributed towards population centers. And so there are clinics and some county hospitals, dispensaries, which are close to where people are, it largely just comes down to they don't have the capacity to address mental health. The staff don't feel confident, the medications aren't there. And so we're really starting to focus at the sub-county hospital level for clinical care. And then for community-based care, really focusing on community health volunteers. The difference between a CHV and a CHW is amount of pay. Largely, most county governments in Kenya have community health volunteers, with 10 community health volunteers making one community unit as part of the Ministry of Health's community strategy. And I think going into it in much more detail will be a larger side. And so I think I'll just say a lot of the counties in Western Kenya don't have, as part of the Ministry of Health and county infrastructure, don't have many community health workers, have more community health volunteers.
Edith and Florence, a couple questions about the role of traditional healers, whether they're playing a positive or negative effect, and if no effect, can they be engaged in a positive way? And also about syringe exchange programs, harm reduction, whether injection drug users are part of the population that's being served through these substance abuse programs.
I'd like to talk about the traditional healers. I know in Western Kenya specifically, we have not focused on that. And I know that there's a colleague of ours, a senior professor, and if you read around, a lot of the research is done. He's done work around traditional healers and demonstrated that yes, they can be utilized. We just haven't focused on that specifically. And probably it's because of our own convictions, maybe. But yes, they have a role in the sense that because of the misunderstanding of mental illness, many people would actually seek help at a traditional healer or a religious leader. So we have engaged the religious leaders and then encourage them that even as they pray or cast out demons, that they should consider that this is an issue that can also be treated at the hospital, but we haven't explored that. And probably it's because of individual interest, but there's a room for them to be engaged. I think I'd want Florence to mention something about the syringe exchange program and harm reduction, especially in future, because we haven't done that practically in Western Kenya for now.
Harm reduction strategies are being used now in Kenya, particularly for opioid abuse. That's heroin, pethidine, and it's largely two forms. One, it's oral methadone for opioid addiction, but two, it's also needle exchange programs, and these are mostly run by the government, but there's also heavy involvement of donors and the non-governmental organizations. So that's already happening in the country. Unfortunately, a lot of those services are in specific parts of the country. So that would be in the urban areas, that's around Nairobi, the coastal region in Mombasa, where there's quite of opioid abuse, and also in Kisumu. So lots of people, including in MTRH, are not able to access harm reduction strategies for opioid abuse. And right now, me and Edith are working towards have that being available, at least in Eldoret and at MTRH. So even though harm reduction is very controversial, but I'm happy to say that it's part of substance abuse treatment in Kenya.
Great. Other questions? People want to unmute themselves? 1 or 2 minutes left. Any final comments from our panel?
I know one of the emailed comments before the talk that was emailed to us was about how to address stigma and awareness in the community. And so I think we could address that one. I think we addressed it a little bit during the talk, but maybe all three of us can comment quickly on kind of addressing stigma. Koba, do you want to start?
Yes, so I always look at stigma from a point of when people feel like there's one group of people who are very, very different, and that we, on the other hand, are better. And then, so that difference is what brings about stigma. And so to me, the main way of addressing this is really educating the public and anyone. I call it the gospel of mental health, that I try to preach to anyone who cares to listen, that if we understand that anyone who has a brain is at risk of getting a mental illness, and that is not for a select few, and it's not because of witchcraft, it's not just because they are stressed out or because they come from a certain family that they got mental illness, then we begin to fight the battle of all these mental illness is different. And even at the government level, we'd be able to convince them that these two human beings who just suffered from something that went wrong in the brain deserve as much care as anyone who got a problem with their leg or any other part of the brain. So how I see it being addressed is education. And I want to say that in Kenya, I feel like we are making some progress. And unfortunately, it's come out of the suicides that are being reported. And we finally saw a task force being put up together in Kenya, just because people were more aware that really it can affect, and it can affect people who are closer to us. So education. And that is why we start for all the effort that we are putting in, we really put a lot of emphasis on educating the public, whether it's a teacher, whether it's a police officer, whether it's a church elder. Everyone should know that it's not an illness for a select few. It can affect anyone, including we, the professionals, and that is not witchcraft. And when we keep doing that at any given opportunity, and one of the things we've been trying to do is even engage the radio station, the very local radio station, not the complicated ones. So at any given opportunity, we talk mental health. And as we talk about it, it becomes less stigmatized, and people begin to appreciate that it can affect anyone, and they do need help, and it can be also treated. Because that's the other question that I see many people asking me, can this patient get better? And I keep giving examples. I tell them we have nurses, doctors, engineers who are on treatment, and they are doing well, they are continuing with their work. So that's what I'd say about stigma.
Florence, do you have anything to add on stigma?
Well, yes. Other than education, that I think needs to be really consistent, is to also begin to include people with lived experiences into mental health programming, including them in developing policies and reviewing legislations, in planning mental health programs, just even letting them go out into the community and talk about their experiences if they are willing. I find that it really helps to destigmatize and to demystify. I've seen that particularly with alcohol. When someone who's experienced addiction and has gone through treatment and has recovered, and they're able to speak about it, it helps to reduce the misconceptions that that people have about that particular illness. So I think it's really important for us to begin including people with lived experience in the work we do.
And I would just add to all of that our current efforts to address stigma are largely looking at as kind of two main categories of the general population, of kind of putting into other programming for chronic diseases, for interactions with the general community, radio shows, and then really seeking community leaders, both politicians and chiefs of villages, educators, and really taking opportunities as they present themselves. I think an opportunity that we didn't expect to come up was, as Wasin Gishu County had a quarantine facility for people who broke the rules of social distancing and curfews, with several hundred people in it. We were invited by the county to do mental health screening in that in those facilities, which kind of improved our relationship with the county. And the police commissioner approached us to do mental health sensitization for all of the police officers in Wasingishu County. So in the last quarter, we held 35 sensitization sessions and sensitized 667 police officers in Wasingishu County, which I think was a huge opportunity, both in terms of a population that has increased risk of mental health, much like healthcare workers do, and a population that interacts with mental health, people with mental health disorders on a regular basis, and can put people with mental health disorders in very dangerous circumstances. And so I think that was a really exciting opportunity, and hopefully we'll be able to kind of expand that to other counties as well.
Well, I think time is short, so I just want to thank our panelists for really a wonderful set of presentations, especially Florence and Edith for giving us your evenings, and Matt with everything else you've got going on, giving us your time too. So thank you, all three of you, for really helping to illuminate this and show us what great work you're up to. I do want to put in a plug for next month. Our chat will be held on December 1st, which is World AIDS Day at noon, 8 p.m. Kenya time. And the topic is going to be on HIV and COVID-19 in Kenya with an update from Professor Kamayo. And we'll also include Professor Joe Mamlin, our founding father, and Daniel Ocheng, who was one of our first HIV patients. In fact, our first HIV patient in AMPATH to be treated. So we're looking forward to that presentation, and please feel free to welcome to join us at